Welcome to the deep dive. Today we're jumping straight into the clinical atlas of ocular oncology. Our mission here is really to give you, the learner, a clear and organized summary of some very dense material.
Exactly. We want to cut through the noise and get to the clinical bold.
And the book's core idea is, well, it's pretty unique. It doesn't organize tumors by the final diagnosis you'd write on a chart.
No, it doesn't, and that's the key. It organizes them by the two things you see immediately in the clinic: color and location.
Which is such a powerful shift in thinking.
It is. It forces you away from a huge list of differentials and makes you ask a much more practical question. Okay, based on how this looks and where it is, what are the, say, four most likely things this could be? It's a clinical shortcut.
A triage system, really, so it breaks things down into, four main color groups?
That's right. Black, gray, brown, tan, yellow, white, and red, pink. And it maps those across locations: extraocular, optic disc, retina, choroid, and so on.
I found it interesting that this leads to a kind of random order of conditions.
It seems random, but it's perfect for training. It forces you to compare lesions that look similar but are fundamentally different. And that really hones your diagnostic skills. You start to see the subtle variations.
Of course, color can be subjective. I mean, is a lesion brownish gray or is it black gray?
Right, there's some unavoidable overlap. But the goal isn't perfect categorization every time. It's about narrowing that diagnostic field effectively.
So before we even get to imaging or anything else, the atlas puts a huge emphasis on just meticulous documentation.
Absolutely. For any learner, this is non-negotiable. You have to follow a standard template for every single lesion.
What does that include?
The essentials are location, color, structure, precise dimensions, and the extent of its spread. But just as important, you have to document any effect on the healthy tissue next to it and any other coexisting morbidity.
Because that initial record is the baseline. It's what you compare against later.
Exactly. Change over time is often the biggest clue we have in oncology.
Okay, so we've documented. Now we move to imaging. I was struck by the book's warnings about the equipment itself.
Yes, this is a huge clinical pearl. We all use color photography, but different cameras render color very differently.
The Optos camera, for instance.
The Optos is notorious for it. It can make a truly amelanotic tumor one with no pigment look pigmented. If you don't know that, you could be completely misled.
A critical technical limitation to be aware of. And beyond that,
our workhorses are OCT optical coherence tomography and high-frequency ultrasonography. They give us that cross-sectional view and deeper structural information we need.
Which brings us to the point where you often need to get tissue. Let's talk about biopsy. This seems like a really high-stakes moment.
It is. A biopsy is often the only way to get a definitive diagnosis, especially to tell an in situ tumor from an invasive one.
And for something like a nodular conjunctival melanoma, the technique is paramount.
It is. The gold standard is an excisional biopsy using a no-touch technique.
Can you break that down for us? What does no-touch actually mean in practice?
It means you minimize any contact with the tumor itself during the excision. You handle the tissue around it. Then you use a completely fresh set of instruments for the closure. The whole point is to prevent any malignant cells from being transferred or seeded into healthy tissue.
So you're not spreading the cancer yourself.
Precisely. The stakes are incredibly high.
So when would you not do a full excision? When is an incisional biopsy the right call?
You'd reserve that for lesions that are just too big or widespread to remove all at once and block, as we say. Think of extensive conjunctival lymphomas or a really diffuse primary acquired melanosis.
And once you have that tissue, the job isn't done.
Not at all. Communication with the lab is critical. You need timely transport in the right medium, and you have to give them orientation mark the corneal edge, for example. Otherwise, the sample can get crushed or scroll up, making it useless.
It's that whole workflow, from the first photo to the lab handoff, that defines good practice. And then, of course, any confirmed malignancy gets staged.
Correct. According to the latest AJCC Cancer Staging Manual, that sets the standard for everything that follows.
Okay, let's move to the external eye now. Extraocular lesions, specifically on the conjunctiva. This is where that color system really starts to shine.
It does. Let's start with the black-gray category, which is mostly melanocytic stuff.
So a benign conjunctival nevus versus a malignant melanoma. What are the key differentiators?
A nevus often has these large cysts inside it, and crucially, it usually lacks feeder vessels. A melanoma is typically solid and vascular.
And the book makes a really important practical point about location.
Yes. If you see a nibus on the non-bulbar conjunctiva like on the placa or caruncle, it's often excised even if it looks benign.
Why is that?
Because surveillance in those areas is really difficult.
Okay.
And while malignant transformation is rare, the risk of metastasis from those locations is higher, so the threshold for removal is much lower.
Got it. Now, contrast that with a confirmed conjunctival melanoma.
With melanoma, you absolutely must use that strict no-touch excision technique, and you have to be so careful not to perforate Bowman's membrane,
Which acts as a barrier.
a crucial barrier to prevent the tumor from spreading inside the eye. Recurrence dramatically increases mortality, so that first surgery has to be perfect.
We also see that slate gray color with congenital ocular melanocytosis.
Right, that deep pigmentation. The key there isn't immediate treatment, but lifelong surveillance, because those patients have a small but increased lifetime risk of developing uveal melanoma.
And what about other pigmented lesions, things that aren't melanoma?
You should always be looking for clues. Pigmented squamous intraepithelial neoplasia, or CSQIN, for example. It often has this gray keratin on the surface and these really large looping feeder vessels. Those are big clues.
Okay, let's shift to the red, pink, or yellow lesions. These seem more inflammatory.
Often, yes. A classic example is a pyogenic granuloma. It's bright red, nodular, pops up suddenly, and is very vascular. It looks dramatic, but you still need a biopsy to confirm.
And for the yellow or pink ones?
You might be looking at reactive lymphoid hyperplasia. This one is a great diagnostic challenge because it can actually shrink with just fluoromethalone drops.
So you might think it's just inflammation and you've treated it.
Exactly. But you have to biopsy it. You need to prove it's a polyclonal proliferation of B and T cells to definitively rule out a true malignant lymphoma. You can't skip that step.
Oh, perfect example. Now, let's say we've done an excision or we're managing a diffuse process. What about adjunctive therapies? Chemo and radiation.
Topical chemotherapy is a mainstay. We often use 5-fluorouracil or 5-FU. A typical regimen is 1% 4 times a day for 4 days, repeated in cycles.
And the author mentions a preference for another agent.
Yes, for mitomycin C or MMC. The preferred protocol seems to be 0.04% 4 times a day for 1 week, repeated every month for 4 months.
That intermittent schedule is interesting. It must be about managing toxicity.
It is. These drugs cause a lot of inflammation. That's why the management plan is so detailed. You advise the patient to use Vaseline on their lower eyelid, to wear gloves when they put the drops in.
To protect the surrounding skin.
Right. And you almost always co-prescribe FML drops to manage the ocular surface discomfort. It's a whole package, not just a prescription.
And if chemo isn't enough,
Then radiotherapy is the next step. That can be brachytherapy using small radioactive plaques, or the more focused proton beam radiotherapy.
okay, let's go deeper into the eye. Choroidal lesions. The book notes that while naevi and melanomas can be anywhere, some other tumors have preferred locations.
That's right. Hemangiomas and metastases, they tend to be more posterior, often near the optic disc.
And here, the physical features get really nuanced. Let's start with shape.
Shape is key. A melanoma can be nodular or diffuse, but if you see a mushroom or collar stud shape, that is almost pathognomonic.
Why does it form that specific shape?
It happens when the tumor grows and pushes up against the tough inner barrier of the eye, Bruch's membrane. When it finally breaks through, the pressure is released and it just balloons out under the retina. That's what creates that classic shape. Metastases, on the other hand, are usually flatter, more plateau-shaped.
And color assessment here is tricky, right? Because of the overlying tissue.
Very tricky. A tumor with no pigment, and a melanotic tumor, can look brown or gray simply because the overlying RPE has reacted and become thicker or more pigmented.
So how do you get around that?
We use tools like transpupillary transillumination to get a better sense of its true color. But the biggest color-related red flag is seeing confluent clumps of orange pigment.
Lipofuscin.
Exactly. It's a waste product from stressed RPE cells, and it tends to accumulate specifically overgrowing choroidal melanomas. You almost never see it over a benign nevus. It's a very strong sign of malignancy.
That's a huge diagnostic takeaway. Now, with ultrasound, we can look at the internal structure, specifically the acoustic reflectivity.
Right. It's about how sound waves bounce off the tumor. A calcified lesion like an osteoma will be a very high reflectivity. A hemangioma is high. Metastasis is typically medium.
And the key one,
Malignant melanoma is characteristically low internal acoustic reflectivity. Its dense, uniform cells just absorb the sound. This is a critical piece of the puzzle.
so we have shape, color, size, reflectivity, a lot of data points. The atlas gives us a tool to synthesize all this, the MinLS. system.
The MELAS acronym is a fantastic tool. It's a scoring system to help you estimate the likelihood that a melanocytic choroidal tumor is malignant.
Let's walk through it for everyone listening. M is for.
M is for mushroom shape. If you see that collar stud, that's 2 points right away.
O is for.
Orange pigment, those confluent clumps of lipofuscin we talked about, another 2 points.
Yeah, L is large size.
Right, and size is critical.
Yeah.
If it's thicker than 2 millimeters or has a base diameter over 4 disc diameters, that's about 6 millimeters, it gets 2 points.
And just for reference, 1 disc diameter, or DD, is about 1.5 millimeters.
A good benchmark to remember. Then E is for enlargement. If you have photos showing definite growth, that's an automatic 2 points.
And finally, S.
S is for subretinal fluid. If you see serous fluid or retinal detachment that goes beyond the tumor margins, that's another 2 points.
So you add it all up, what do the scores mean?
A score of 0 is likely a common nevus, just observe. 1 is a low-risk nevus. 2 is a high-risk nevus, so you watch it much more closely.
And the cutoff.
Any score greater than 2 puts it into the probable melanoma category. That means you need to act.
Okay, moving even deeper now to the posterior segment.
Yeah.
One of the toughest diagnoses in all of ophthalmology has to be vitreoretinal lymphoma, or VRL.
It's a notorious mimic. It often presents as a severe posterior uveitis that just doesn't respond to any standard treatment.
So the diagnosis has to come from a biopsy.
It does, a vitreous sample. And the sampling here is incredibly demanding. You need a large volume of undiluted vitreous, and it has to get to a specialized lab that you've pre-warned within an hour. Cell viability is everything.
And what are we actually looking for clinically?
You might see these hazy pearls or clouds of lymphomatous cells floating in the vitreous. Interestingly, these cells can also sneak through the RPE and build up underneath, appearing as these creamy yellow-white tumors.
Let's pivot to retinoblastoma, or RB. Specifically, for patients in treatment, monitoring is all about looking for specific regression patterns.
Yes, these patterns tell you if the treatment is working. There are 4 main types.
What's type Y?
Type I is cottage cheese regression. It's a white, crumbly, calcified mass. That's a good sign.
Okay, type 2?
Type 2 is fish flesh regression. This is more translucent, soft, residual tumor. It's less ideal because it might still contain viable cells.
Yeah, types 3 and 4.
Type 3 is just a mix of I and 2, and type 4 is the best outcome. A flat, atrophic scar, often with some pigment changes around it. That means the tumor is gone.
Let's wrap up this section with optic disc lesions. The book reminds us most of these are secondary.
That's right. Most tumors you see on the disc actually started in the choroid or retina next to it and grew in. Imaging here is indispensable. OCT can find things like buried drusen, and MRI is critical for checking for retrolaminar spread, especially in retinoblastoma.
This has really been a fantastic deep dive. It underscores how powerful a simple framework can be, using color and location, then layering on imaging and structured tools like MELAS.
It really is about synthesizing those observations under pressure. And to help with that, maybe we should run through a quick exercise using the MELAS system.
I love that idea. A practical test. Go ahead, give us the scenario.
Okay. A 65-year-old patient comes in. You see a choroidal lesion. It is clearly mushroom-shaped. You observe confluent clumps of orange pigment. Its basal diameter measures 4 dd. You have records showing definite growth over the past year. And there is a definite serious retinal detachment extending beyond the tumor margins. So using the MELAS system, what's the total score and what's the management category?
All right, let's tally it. Mushroom shape is 2. Orange pigment is 2. Large size. 4 dd is the threshold, so that's 1 point. Definite growth is 2 points. And subretinal fluid is 2 points.
So the total is?
2 plus 2 plus 1 plus 2 plus 2. That's a total square of 9.
Correct, a score of 9. And based on the classification, anything over 2 is?
Probable melanoma. That system gives you a very clear high-risk flag. It's incredibly powerful.
It is. It turns a complex picture into a clear directive.
So as we wrap up, what's the one provocative thought you think we should leave our audience with?
I think it's about the absolute necessity of precise anatomical localization. You have to remember that a benign condition, like scleral calcification, can just sit there and compress the choroid from the outside, making it look like a tumor. It can mimic a deadly uveal melanoma, which actively involves and grows from the choroid.
So the distinction is critical.
It's everything. Using tools like enhanced depth imaging OCT to determine if a lesion is in the sclera versus in the choroid isn't just a neat trick. It's absolutely essential to avoid a misdiagnosis and potentially devastating unnecessary treatment.
A profound reminder that in this field, knowing exactly where you are anatomically is just as important as what you see on the surface. Thank you for walking us through this today.